Good afternoon, everyone. Thank you for joining us today for our Innovation Theater. I'd like to welcome Dr. Tamara Clodi-Seitz. Dr. Seitz works at the Department of Infectious Diseases and Tropical Medicine in Klinik Favoriten in Vienna, Austria. Dr. Seitz is finishing her PhD in rapid diagnostics of bloodstream infections, and today she's going to be presenting stewardship-guided T2MR testing, prognostic role and clinical implications of culture-independent systems in patients with bloodstream infections. Thank you.
Thank you very much. Thank you for being there. Today I want to address a really pressing global concern, bloodstream infection and sepsis. And like Oscar said, especially talking about the prognostic role and clinical implication of culture-independent systems. These are my disclosures. Sepsis. It is estimated that about 48.9 million cases worldwide are every day. About 11 million persons are dying every year worldwide due to sepsis. This is about 20% of all global deaths. So we all know it's a really, really big issue worldwide. If a person is suffering from sepsis, the mortality is really high. For example, in Europe, it's 23.9%, and if septic shock is present, it's even over 30%. So time is of essence, given that each hour of delayed treatment increases the mortality by 7.6%. So it's really important that we know the causing pathogen so that we are able to treat the patient sufficiently, and it's also important to get a targeted therapy. So the targeted therapy enables a sufficient therapy, of course, and less side effect for the patient, and a decreased risk of antimicrobial resistance. Anyway, it's not always that easy. So the standard of care method are the blood cultures, for example, or multidoph, but they have several disadvantages. For example, in most cases, the sensitivity is not really high. For example, if antimicrobial therapy is already ongoing. Further, the blood culture needs extended incubation periods, and this leads to a delayed pathogen detection and treatment. So we luckily have the culture-independent methods. For example, the next generation sequencing. The next generation sequencing is not available in all departments. It's still quite expensive. We also have the PCR and T2MR. They offer a faster detection of pathogen, and in most cases they are even more sensitive than the blood culture. They have the limitation that they're just detecting a limited number of pathogens. But anyway, I want to show you what are the other advantages of it. So for example, here you can see the T2MR instrument. You need 3 to 4 milliliters blood, and then you put it in the cartridge and put it in the instrument, and after 3 to 5 hours, you get the result. It's really easy to use. We have it in our department as well. As a point of care laboratory, everyone is able to do that. Another advantage is that the technology is not inhibited by present antimicrobial therapy. So far, we have 3 T2 panels available. The first one is the T2 Candida panel. It enables a detection of the 5 most common Candida species in blood: the Candida albicans, tropicalis, parapsilosis, cruzi, and glabrata. The second one is the T2 bacteria panel. It detects the 6 common or 6 important pathogens causing bloodstream infection: Enterococcus faecium, Staph aureus, Klebsiella pneumoniae, Actinobacter baumannii, and Pseudomonas aeruginosa, and E. coli. And the third one is the T2 resistant panel. It's detecting the most common resistant genes. For example, in the gram-positive area, you have the MAC-A-C, or in the gram-negative, KPC, NDM, MC. Here again, you have the result after 3 to 5 hours, so you can start with targeted therapy even if multi-resistant is present. There were already several studies performed about the performance of T2MR, for example, the T2 candida panel. It was compared to blood culture, and it could be shown that the sensitivity and the specificity was quite high, about 88.9% to 89%. And also some clinical studies were performed where they look at population with high risk of candidemia with a prevalence of 5 to 10%, and could see that the positive predictive value of T2MR was about 70.6% to 84.2%, and the negative predictive value was nearly 100%. So it's a much better performance than blood culture. Interestingly, some authors looked at the question whether you can use the T2MR to detect fungal infection in patients with COVID-19. Fungal infection were a huge issue during COVID-19. All of them already received antimicrobial therapy, antifungal therapy, and they could see that the T2MR enables a faster detection and a faster possibility to change to targeted therapy. And one author also looked at the costs and could see that in patients with an increased risk of candidemia, for example at oncology, you can save money if you're using the T2MR. T2 bacteria panel, several studies were performed about sensitivity and specificity compared to blood culture. It's quite high. And here again, in patients with COVID-19, severe COVID-19, if they have antimicrobial therapy ongoing, T2MR can be used to get the causing pathogen for the bacterial superinfection, and that results in a better outcome for the patients. So to sum up, there's already several studies showing that the T2MR enables a faster and a more sensitive detection of pathogens. There's also a meta-analysis of 14 controlled studies. They were performed in different countries. And they could see that if you're using a T2MR in addition to the blood culture compared to the blood culture alone, there's a faster time to the detection of the pathogen. It's about 81 hours faster. The time to species identification is 77 hours faster. And you can also be able to get the patient an earlier targeted therapy. So for example, if the patient has a negative result on the T2MR, the physician is able to de-escalate from empirical therapy 7 hours faster. And if they have a positive T2MR result, they receive the targeted therapy 42 hours faster. And there was also a trend shown that they have an implication to the clinical outcome of the patient. So if you're using T2MR in addition to blood culture compared to blood culture alone, the length of ICU stay was 5 days shorter compared to blood culture alone, and length of hospital stay was also about 5 days shorter. So it's really, really impressive results, but there's one question that is still open, and this is whether you can use the T2MR for serial testing to check for pathogen clearance. Like you're, for example, doing with Staph aureus bacteremia with blood culture every 2 days. So to address this knowledge gap, a really interesting study was published, the STEM trial. This was a monocenter prospective study, and the authors included 31 patients with bloodstream infections with Candida species. They performed a serial testing with T2MR, the T2 candida panel, and then the blood culture, first on the day of enrollment, so day 0, day 3, day 5, and day 7. And the first interesting result was they could show that the T2MR is positive a longer time compared to blood culture, showing that the T2MR offers a higher sensitivity compared to blood culture, even if antifungal therapy is already started. Anyway, the study only included 31 patients. That's not really much. The sample size is really, really low. So further studies have to be performed to really get the clinical implication on that. A different study was performed, including patients with bloodstream infection, bacterial bloodstream infections. This was a multi-center prospective study, recently published, and they included 102 patients with bloodstream infections, including the escape pathogens, so that are only the pathogens that are included in the T2 bacteria panel. Again, it's the E. coli, Staph aureus, Klebsiella pneumonia, Acinetobacter, Pseudomonas aeruginosa, and E. faecium. And they performed a serial testing with T2MR and blood culture on day 1, day 2, day 3, and day 4. And the aims were they wanted to look whether the time of pathogen clearance was different in blood culture and T2MR, similar to the other study. And the other aim was to see whether there's an association between the prolonged detection of pathogen with T2MR and clinical outcome. So the prolonged detection of pathogen was defined as a pathogen detection over 4 days, about the study period. And first, they could also show that the T2MR is longer positive over the follow-up of 4 days compared to blood culture. So also the T2MR seems to have a higher sensitivity if you already have an antimicrobial therapy ongoing. And also they could show that if you have a positive result in T2MR after 4 days, and again, remember you get the result after 3 to 5 hours, so really get on day 4 the result. There's an association between the prolonged pathogen detection and the metastatic infection. So for example, if there's an endocarditis or deep tissue abscesses. So there's still, the sample size is still not really high, but it's really interesting for the clinician to see whether there is, on day 4 already, whether there's a high risk, for example, of endocarditis or not, and to press the cardioradiography. Further, there's an association with source control failure. So for example, if you had a candida-related bloodstream infection, it's still positive on day 4. You have to look whether the central vein line is still there and you have to remove it. And there was an association between the prolonged pathogen detection and the lack of SOFA improvement at day 7. SOFA score is a clinical sepsis score, so it is associated between the lack of improvement of the patient. Really, really interesting paper, in my opinion, but again, they looked at 6 different pathogens, included 100 patients, so we need more results to really know what's the clinical implication there. And to address this, we have a study ongoing in Vienna in our department, and we want to look at patients only with Staph aureus bacteremia. Study is still ongoing, but the first results are really nice. So we are including patients with Staph aureus in blood culture, and we perform T2MR and blood culture at day of enrollment, day 2, day 4, day 6, and then every 2 days until both are negative, so blood culture and T2MR. We follow them up quite long, about 90 days. So if the patients get discharged, we call them at day 90 and ask them how they are doing. And we are looking, for example, for hospital stay, the duration, the modality, of course, and then whether they get readmitted to the hospital due to Staph aureus bacteremia or any complication or due to other reasons. So far, we included 22 patients. Most of them had a skin infection or a candida-related bloodstream infection. We could also see that the mean clearance time of T2MR was longer than compared to blood culture. So with T2MR, it was 5.5 days compared to 3.7 days. And the first result also showed that there's an association between the prolonged detection of T2MR of Staph aureus and clinical outcome. So for example, in patients with an detection time over 3 days in T2MR, compared to those who have it less than 3 days, have a higher risk of persistent infection. We said persistent infection is if there's any metastatic infection present, like endocarditis, or a lack of source control, like the catheter that's still there. There's a higher 30 days mortality. So you can see the 30-day mortality in the prolonged detection is 54.5% compared to 9%. And there's a longer hospital stay. And in patients with a Staph aureus detection over 7 days, that happens as well, the risk in our population of a persistent infection was 100%. The mortality was higher as well, and the mean hospital stay was 33 days compared to 16 days if the clearance was less than 7 days. So the study is still ongoing. 22 patients are not that much, I know that, but we really, I think the first results are really impressive. I'm really looking forward to do the rest of the study, and hopefully we'll be able to present it at next ESCMID to see how this is going. So, to sum up, culture-independent methods like T2MR are really useful and enable, compared to blood culture, a more sensitive detection of pathogen, a shorter time until detection, so we can start an earlier targeted therapy. It's important to say that you should use, in my opinion, the T2MR only in addition to blood culture or other cultures, because you just have a limited number of pathogens, and you have an antibiogram in the blood culture. Prolonged pathogen detection by T2MR is associated with persistent infection. So, for example, if you have a lack of source control or endocarditis and a worse clinical outcome. Anyway, we need further studies to really bring that into the guidelines or see how the clinical implications are there. But there's a lot of studies ongoing, and I think in the next years we will know more about it. So, thank you very much. I'm happy to answer all your questions.
Look, I would like to ask you, when you make some testing comparable the T2 with the blood culture, how do you resolve the discrepancy? I mean, a positive result for T2 and a negative result for the blood culture. How do you resolve this?
You mean in general and in this study?
In any study and in any situation that you find these discrepancies.
Yeah.
How do you solve that?
If the blood culture is negative and T2 is positive,
Exactly.
yeah?
Exactly.
I mean, we are using the T2MR in our clinic on like normal patient without study as well. And we are just checking whether the pathogen is like common for the disease the patient is, or the clinical presentation. And normally we are believing the T2MR. Of course, we are always like skeptical. But in our opinion, I mean, we performed a lot of studies about that and COVID-19 as well, and compared, for example, the T2MR with cultures of other specimens, for example, respiratory secretion. And there's, most of the time, there is like a really good fitting. Do you know what I mean? So we have Pseudomonas aeruginosa in the T2MR and have it in a bowel as well. So we're always doing other cultures as well, but if the pathogen is fitting to the clinical presentation, we believe the T2MR.
Okay, and this is also the opinion of the clinical doctors that are following everything. Also.
In our department, yes.
Okay.
But at first, to be honest, we were quite skeptical. But we have really good experience with that, yeah.
Good.
But of course, there are cases when we say, okay, no, we don't believe that really, but in most of the cases, yeah, we trust the result, yes.
Okay, thank you.
Any other?
So, which patient you are offering the T2? All the patients with sepsis, only in the CCAR unit? Which criteria you are using to do the T2 together with the blood culture?
So just to be sure that I understood your question, you mean in which patient population we use the T2MR? So at first we started with the T2MR about 6 years ago. We just used it in study designs. Right now, during COVID-19, we used it if the patient is on ICU with severe COVID-19, we are suspecting a superinfection, like fungal or bacterial superinfection. And right now, we're using it at the intensive care unit if the patient has a high risk of bacterial fungal infection and time is of essence. For example, at the weekends, we don't have a pathology, so we're doing the T2MR. But it's a decision that every physician is doing. And we are also using the T2 candida panel quite often if a fungal infection is suspected, because we have a really low sensitivity with blood culture. So all patients on the ICU that have signs of infection don't get better after 3 days of antimicrobial therapy. Oncology, pediatric, same time as well, yeah. But we don't have like the clinical criteria.
Oh, thank you. That was a great talk. So I noticed that for the T2 bacteria panel that the sensitivity compared to blood cultures was only 90%. Is that just because the blood culture is detecting some pathogens that the T2 panel is not, or does it sometimes like miss a Staph aureus or something like that?
Yeah. I mean, yeah, in this study, I didn't perform the studies, but yes, I mean, of course, in some cases, the T2MR is worse than the blood culture, but it's really, really rare, in my opinion. Yeah, I mean, 90% sensitivity seems quite low, but I'm pretty sure if you're seeing it on the clinical studies, it's higher compared to blood culture for the escape pathogens. Yes.
So thanks for the talk. In your study, how did you diagnose persistent infection? Were all study patients screened for persistent infections, or only the ones that had prolonged T2 positivity?
Could you speak up a little bit? Sorry.
Sorry. How did you diagnose persistent infection in your study? Did you screen all patients for persistent infection, or did you only screen the ones that were T2 positive over longer time? So how was that done?
The study about the specificity was not done by me.
I mean,
It's the Staph aureus bacteremia. We performed that, and we performed a couple of studies with COVID-19 patients.
no, in the study that you showed the data at the end, these 20-something patients, where you said if T2 is positive longer,
Yeah.
they have more persistent infection.
Yes.
So did you screen all your patients at regular time points, like 3 days, 7 days, 14 days
No.
for persistent infection, or how did that work?
No, we're trusting. So the patient in all our whole hospital are included, and if one patient in any department gets a Staph aureus bacteremia in blood culture, we are called and we're going there and getting the T2MR result as soon as possible. So we're not screening them, we're just following up, but the the Staph aureus bacteremia has to be present at first.
Yes, but how did you diagnose persistent infection clinically?
Persistent, okay. I mean, it's like the normal Staph aureus guidelines. So, of course, we are doing echo for every patient, normally advanced ultrasound echocardiography. And if the blood culture is longer as well, I mean, we're looking for CD, but we don't have like the clinical criteria they're doing on day 7, the echocardiography, but we're just only doing our normal clinical use. But all these patients are in our department and we are infectious diseases, so we are really following the Staph aureus guidelines. But of course, I know we will not find everyone who is having a metastatic infection, but we are hoping to find it if we're following up for 90 days. So maybe the patient gets readmitted because I don't know, stroke or anything, and then we can look whether that's maybe a Staph aureus complication. Yeah. But of course, it's a limitation of the study.
Any other questions?
Yeah, in your study, so you follow the blood culture and the T2, and you see that maybe the blood culture is negative, and T2 still positive, right? So, but because of some error, right? That usually on that patient you give antibiotic already, right? So it can change a lot for the blood culture. However, do you assess the clinical response? Like you see the patient have a fever, CRT, or level of procalcitonin, corresponding to the blood culture negative, or is there any case with in patient with T2 is positive, but the patient get improved a lot about the clinical
Really interesting question. Yes, of course. So the study design is quite complicated. So we look at every day, every follow-up day, like day 2, day 4, also in inflammation parameters, like white blood counts, CRP, procalcitonin. We're looking at the clinical response, SOFA score. We have the hospital recovering score, at the ICU stay, etc. And so far, we did not have any case where the patient was really doing well and the T2MR was still positive. So, but it's still 22 patients, so it's not really much. But yeah, we correlated clinical improvement as well with the T2 and blood culture. But we want to include at least 50 patients to calculate that. We didn't do that so far. And interestingly, we also had 2 patients with a negative blood culture, and the T2MR was positive. And we performed another blood culture in T2MR after 3 days, and the blood cultures came positive again. So I think that's also an issue, that the blood culture is getting positive then again. And that, I think it's the proof that the T2MR is true positive. Yeah.
Do we have time for another question? Yeah, perfect.
Thank you for the great talk. Sorry, I missed the Q&A, but so I apologize if someone already asked. But I was wondering, so are you also using like the molecular AMR targets, or you just using the panel with like bacteria present absent?
What are you using also?
So you mentioned in the beginning that there is, the kit for detection of bacteria and then for detection of resistance markers. Are you also testing those markers or
No.
just the bacteria?
Actually, we discussed it in our team, but we don't have a really high rate of resistance in Vienna so far. So we decided not to use it, but in future we may. Yeah, but in this study we didn't use it. Yeah.
But I'm wondering, as you're a clinician, right? So,
Yeah.
like, what's your view, like, on use of molecular for, guiding the antimicrobial therapy in terms of, like, if you get these resistance markers and you say, you have your results earlier than the culture,
Yeah.
like, would you treat based on that, or like?
Yes, of course.
You would.
Yeah. I mean, I think the resistant genes are the future, because in most time you know what's the best therapy then, or you can at least suggest it. And I mean, we have a really rising number of NDM. It's resistant to cefiderocol as well, and then we have to do like the synergism testing. And if you know after 5 hours you have an NDM, you're treating the patient completely different. So yeah, I think it's useful, but you still have to know whether you have like the resistance rate is high enough to use it, because it's still not. Yeah, I mean, it costs something. But I think in future we will use it. So at first use the T2 bacteria panel, and it's, for example, Acinetobacter at the resistance panel, so we know what to do then, yeah.
Thank you.
Any other questions? All right, well, thank you, Dr. Clodi-Seitz, excuse me. I'd like to welcome everybody to pass by our booth. We're here. We're going to be here all week. If anybody has any more questions on the T2 panels, whether it's bacteria, candida, or the resistance panel, we're happy to meet with you and talk with you. And thank you for attending the presentation, and thank you to our speaker again.